All right, hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute, located at A.T. Still University in Kirksville, Missouri. Please note that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of A.T. Still University. My name is Corey Lubring, and I am the practice-based research coordinator of DO-Touch.NET and the host of the OMM Research Podcast. Before we get started, we also just want to remind our listeners that this podcast recording has video recorded with it that can be viewed on the DO-Touch.NET YouTube channel if you prefer to consume the episode there. And we want to start out this episode by introducing our panelists for the episode. So we'll start with Dr. Stacey.
Hi, my name is Dr. Stephen Stacey. I'm the Director of Osteopathic Education for the La Crosse Mayo Family Medicine Residency Program and Assistant Professor of Family Medicine at Mayo Clinic.
And thanks for being with us here today. Can I just call you Stephen for the episode?
You bet.
Wonderful. And then we also have Dr. Amendolara.
Hey, my name is Dr. Alfred Amendolara. I'm a PG1 in neurology at St. Luke's University Health Network in Pennsylvania, and also adjunct professor at Nordic College of Osteopathic Medicine in our clinical research department.
And thank you for being with us here today. And can I just call you Al for the episode?
You can just call me Al.
Just call you Al. Thank you both for being here with us today. And you've got a couple of far-reaching ends of the spectrums with quality of research articles here with us today. And we're going to be starting out with an article brought to us by Dr. Stephen Stacey on the effect of OMT on non-specific subacute chronic low back pain, but it looks like they're focusing on Sham treatment. So I'll pass it over to you, Dr. Stacey or Stephen.
You bet. So the title of this article is Effect of Osteopathic Manipulative Treatment versus Sham Treatment on Activity Limitations in Patients with Nonspecific Subacute and Chronic Low Back Pain, a Randomized Clinical Trial. Authors are, I always butcher this last name, Nguyen. I don't know. How do you guys say that name? Nguyen?
Yeah.
Anybody?
Gwen? Yeah, I think.
Gwen? I actually don't know.
I don't know. There is just a whole group of people out there shaking their fists at me right now. I apologize for my ignorance. It's definitely showing. It was published online in March 2021 in JAMA Internal Medicine. Their research question was, does standard osteopathic manipulative treatment produce greater reductions in low back pain specific activity limitations compared to a sham OMT in people with nonspecific subacute or chronic low back pain? And what they found
before
was...
you get into it, I just want to give a shout out that we do have a DO-Touch.NET member on that author team, and that would be Dr. Rafael Zagaro-Prodi, who is a member of DO-Touch.NET on this article's author team. So anyways, continue.
Oh, that's cool. Nice. So what they found is that standard OMT produced a small statistical benefit over sham in reducing low back pain specific activity limitations at both 3 and 12 months. The authors felt like the clinical meaningfulness of that small effect size was questionable, but we can talk about whether we feel like it's questionable or significant.
So as you are introducing this study to us, what do you want to highlight as like your main positive points for this study?
Yeah. You know, there aren't enough really well done trials out there in manual manipulative therapy, whether OMM or other varieties. And this is one that stands out as really having a lot going for it. So they were really pretty deliberate about their inclusion criteria, first of all, where they limited it to adults, but not extremely elderly adults, which may affect how you might interpret the results in your own patient population. But it was 18 to 65 with non-specific low back pain, and it was recruited from a tertiary care physical medicine rehabilitation department in France. So the people providing the OMM were non-physician DOs, so they were osteopaths, French osteopaths, and they provided 6 sessions of standard osteopathic manipulative treatment with a protocol that was physician directed, and they did one treatment every 2 weeks, which mimics a pretty typical clinical treatment. And they had a variety of primary and secondary outcomes that they compared against sessions of sham OMT. And this is one of the things where I think the trial really stands out is the effort they went through to see whether or not the sham was successful. And this is a really cool aspect that I think um, more trials in osteopathic manipulation should adopt.
And
So,
sorry, continue. I didn't know if that was a break. Continue.
so they looked into the credibility of the interventions and the consistency of whether or not the sham was provided in a believable way by ensuring that while, of course, the DO providing the treatment couldn't be blinded to treatment allocation, they recorded each of the visits and had somebody listen to the speech content and the verbal attitude to determine whether or not the DOs were treating the um, the treatments consistently, basically spending the same amount of time, using language that was just as positive, because that was hypothesized as something, and rightly so, I think, something that could influence the treatment outcome. And what they found from that is that the OMT sessions lasted about 3 minutes longer on average, with minor speech differences in some of the domains that they looked at. And somebody mentioned their osteopathic training, even though they weren't supposed to. So, by no means was it perfectly executed, but the fact that they looked so that you could take that into account when interpreting these results, I think is a really positive thing. One thing I would have liked to see them add is whether or not the patients knew whether they were in the treatment group or the sham group. They did not label the treatment as OMT. They just said that it was manual manipulative therapy, and the sham was basically palpation without treatment force being applied.
Mm. So I kind of open it up to open discussion at this point. Like, what are what kind of makes the study be held up at the high standard that you were kind of saying, like, for it being such a good study and everything, apart from just the scrutiny of the effectiveness of the sham. What else was done right in this study?
They set out uh, their main outcomes in advance, and they had a pretty clear primary outcome, and the other ones were labeled as secondary outcomes. And they didn't go fishing for secondary outcomes to see what looked the most significant. Their primary outcome showed an improvement in the mean change of low back pain specific activity limitations at 3 months. And they said that it was a questionably clinically meaningful improvement. They found, about a 10% or so improvement, which, to be honest, I think is pretty good considering the chronicity of the patients they were dealing with and the fact that we have so few treatments that can demonstrate not only improvement in pain, but also improvement in function, I think is pretty powerful. And there's really not much that we do that's going to increase the benefit by more than 10% or so anyway. I mean, it's a benefit that's seen pretty much on par with a lot of other accepted therapies like NSAIDs, PT, SNRIs. And if you were to stack manual manipulative therapy like OMM on top of those treatments, you'd probably find that um, they combine with each other pretty well. And that's, the clinical experience that a lot of us have. Of course, that's not what they were studying, but something that shows about a 10% improvement with, patients that have had pain for on average more than a year, and that was a treatment over 3 months. I thought that's pretty good.
Al, is there anything that you would like to add to that?
Yeah, I appreciate a lot of their methodology. I think it's cleanly done and well explained. In particular, I think their analysis plan is well laid out and justified in their methods, which is unfortunately something that we don't see in a lot of osteopathic research. To be honest, it's something that a lot of clinical trials outside of the really major landmark ones struggle with. Um, so I think that's positive. Um, Overall, this is a well-powered, well-designed, reasonably well-conducted study. It makes me trust the results.
And I think that's the biggest conclusion at the end is you look at the results and you say, you know what, these are results that I think could affect clinical practice. And that's what you want to
Hmm.
see in these studies is you say, this, I think, represents my patients and my practice situation well enough. And they also ask the question in a way that really, if you were trying to prove it wrong, if you were trying to prove that OMM didn't work, this is how you would design the study. You would try to set up everything in favor of a really clean, isolated uh, effect, and noticing all the limitations about how they didn't quite fully meet their endpoint of trying to keep it 100% the same, the communication the same. We don't actually know whether the patients knew which treatment group they were in, so there's a lot of potential for hidden bias there. But that's sort of nitpicking around the edges. I think more OMM studies should be done this way. I think that if we were to have more of that information about whether the patients knew about their treatment allocation, we could start gathering data. And you've heard me say this on the podcast before, gathering data about which sham interventions may be more versus less effective at fooling patients. And that would be really key in helping us design randomized trials with effective controls. So
So,
overall, well done study. Couple things we'd like to see better, but I'll take it.
so then to kind of wrap up discussion on this article, what would you see as being either next steps of the study, or if you think it was kind of like, at a good point where you would move on to something else, what lessons learned would you take from this to recommend to other researchers to emulate in their studies?
Uh, do your homework beforehand. This had a lot of really good methodology put into it. This wasn't just somebody sort of showing up and being like, oh, well, I think I'm maybe, I, it's that time in my career where I think I might do a study. These were professionals. They knew what they were doing. It was adequately
I
powered.
agree.
Obviously, you'd always like a few more patients. So as clinical trials go, it wasn't huge, but as manual therapy studies go, it's one of our bigger ones. And and
I'll
really
say I
going
do
through
think
the
it was appropriately powered, though.
yeah,
I
I
have a
I
hard
think so
time
as well.
faulting, an
Mhm.
N of 400.
All
No,
right. Yeah.
agreed. I think that really does reflect what I would think of as the true effect. I think that's believable.
Hmm.
One thing that I would like to see is this same quality of study conducted with physician providers of OMM, and
Yeah, I
maybe
agree.
they're better at it, maybe they're not as good at it. I don't know, but it would be interesting to see how this would play out in the United States.
Sure.
I think if I had to have a wish list for this, the only other thing I'd be interested in is how this interacts with uh, analgesic medications.
Mm.
Um, I think, Dr. Stacey, you brought up something interesting that, when you start stacking this on top of other treatments, um, this may become a clinically relevant, uh, treatment modality, even based on these results here. So I'd like to see how that interacts. I don't think they did a great job necessarily controlling for that. Um,
And I didn't
and I
see
would have
those
like it
sorts of
might be.
things. Yeah, they weren't really reported out in terms of
Mm-mm. They
differences
had
in
prior
chronic.
use. Yeah, they had prior use, and they had some mention in their analysis methodology that they did some like post hoc analysis to try and correct for some of that. But I would like to see a little bit more thought given to that on the forefront. And
Yeah.
this might be asking a bit too much, but a third arm would have been nice. I would have liked to see this compared to a standard of care.
Yeah, and there are a lot of other things that you could compare as well, like physician-directed
Hmm.
OMM versus protocolized OMM, or even
Yeah.
physician-directed OMM that limits itself to, say, the area of pain rather than one that takes a more holistic approach about all of the
Hmm.
other dysfunction in other body regions. There are different ways that you could throw in another group and say, while we're learning about OMM, could we learn about what kind of OMM might potentially be the most effective?
Sure. Well,
But overall,
yeah.
I'll take it.
Good article. Thanks for bringing that to us this month. And as we trek from one end of the quality spectrum to the other, we do just want to remind our listeners that this episode does have a video attached with it. If you do want to view that on the DO-Touch.NET YouTube channel, that's DO-TOUCH.NET on YouTube, and so you can view the podcast there and consume it in that format if you prefer. And you can see our lovely faces as we discuss these articles. And speaking of articles, we're going to be moving on to the article brought to us this week by Al, which is looking at OMT on sprint performance in young adults. And so I'll pass it to Al to introduce this article.
So this article is called Evaluating the Acute Effect of Osteopathic Manipulative Treatment on Sprint Performance in Young Adults by Quakenbush et al., published in the Journal of Osteopathic Medicine in October of 2025. So this article is looking at the effects of OMT on sprint performance in young adults. They measured 60-meter sprint times and tried to see how much doing OMT or a sham therapeutic ultrasound treatment might impact those sprint times. Their results end up being non-significant. However, they do conclude that OMT produced a slight improvement in performance and that it might not yield immediately measurable results. However, they say that this trend warrants further investigation.
So, what would you like to point out as the high points of this study?
Um, that's a
Good
good
luck.
question.
That's a good point. Well, what do you want to start
I
with the critiques then?
Well, no, I will say I appreciate that they do a fairly good job explaining their methodology. This would be relatively easy and straightforward to replicate. They do go over things in quite good detail. They give clear inclusion and exclusion criteria. They do a good job explaining exactly what they did with each group and explaining their OMT treatments. They give a good protocol for the osteopathic treatments that they conducted. So I think this is all a good start to any paper.
All right,
I
and
will
then
say, yeah,
no, go ahead, and you will say.
I will say that that's I think where the good ends with this. Um, Unfortunately, we can go through all the usuals with some of these osteopathic studies. It's very underpowered. There's really a questionable rationale for why this might work. What the or I guess I wouldn't even say pathophysiological, but maybe the biomechanical basis for their hypothesis is. Uh, their methodology is a little questionable. They essentially measured a single sprint time pre and post treatment. I would expect in a study like this to average a number of sprint times, possibly over the course of either several sessions or several days. I would expect a little bit more uniformity in equipment, um, a little bit of a little bit more uniformity in their participants. Um, there are a lot of things that I think this study is rather weak in. Um, Ultimately, though, I think if I had to give one kind of general thought about this study. It's not so much what the authors did, but it's the fact that this was a study that was taken and published in the first place. I think this is a really reasonably done, commendable, like student kind of project. I think it's interesting. I think there's really valuable learning built into a project like this. I don't necessarily think that this is something that needs to be in the medical literature and published by a journal, especially a journal that I think many of us go to as the source for up to date osteopathic research that should be impacting our clinical practice.
Dr.
Yeah,
Stacey?
I mean,
Yeah.
they certainly were referencing other studies that shouldn't be impacting our clinical practice either. One of the first things that it says at the beginning of the abstract is osteopathic manipulative treatment has been shown to improve athletic performance by enhancing shoulder range of motion, flexibility, and balance in various sports. And I thought that's a curious thing to start this with because I wasn't aware that that had been shown in the literature. So I went to their references, and one of the first alarming things I noticed is 9 references in an article like this. Um, Anybody who has a research agenda that they've been doing this for a while has so many references that they frankly can't even fit them all in. They just run into the journal limitations, so they cherry pick their very best ones to prove their points. And boy, if the ones they picked represent cherry picking, then they picked some pretty rotten cherries. The studies that they used to establish the background of why this might be an important topic are themselves studies that have even less explanatory potential than the present study. And just again, there are also studies that probably should not have been published. Certainly, ones that should not be making any conclusions about how the world works. So I always look for why, of all the things in the world, to ask a question about why this question. And I'm just not left very comfortable that they set us up really well, that this is the frontier of medical research. I think there are lots of other more fundamental questions they can and should have been asking before they got to one like this.
So, Stephen, you kind of mentioned there in that comment, why this question, and Al, you even alluded to, you were questioning the biomechanics even behind this study, and so could you elaborate a little bit more for our listeners on what your concerns are between this supposed connection put forth by the research team between OMT and influencing sprint times, and why you think that's not something that's even potentially feasible?
Well, I think this fundamentally comes down to the fact that they don't provide a good rationale for this in their background. There's a total of 6 citations in their introduction, and really, I think one of them or two of them deal directly with like any sort of sprint impact on sprint time. I'm not. I just there is no attempt to rationalize this from a biomechanical perspective. It's hard for me to tell you why it doesn't make sense because I think the onus is on the authors to convince all of us that it does make sense. These are
Yeah,
not
so
injured athletes. They're not,
right.
we're not looking at recovery time. We're purely looking at does applying OMT to somebody make them run faster?
Yeah, and there are a lot of treatments in this world and there are a lot of conditions in this world, and to justify doing a study to connect some treatment to some patient population, you need some type of background saying, this is why now. I mean, you could just as well take something like, ivermectin and see how well it works against the common cold because people have tried it in COVID, or eh, I don't know, even more randomly, you could just say, um, does pseudoephedrine help people who are trying to auscultate better, so I just don't see why.
Hmm.
I don't know. It's a weird
Yeah.
connection.
It's hard. I think we're having trouble articulating this because it's really hard to convey that these really are two random things that have been chosen.
Sure, sure.
Uh, there's nothing that I can think of that would lead to this hypothesis necessarily. Which
And it's fairly common among people who choose to focus on some modality or other to see that modality as being effective in a wide variety of things. So you don't have to convince DOs that OMM works for this, that, or the other thing. But ultimately, this is not a study that could ever convince somebody who isn't already convinced, right? This is not persuasive. This is this is not what's the word I'm looking for? Um, it's
well, it's a bit of a
sorry,
presumptive study.
you're gonna have to cut out
It's
my
all right.
voice again. It's that there's a word that means you're trying to like prove something. It's not persuasive. It's anyway. So I'll just go back. Um, yeah. So this study really will persuade anybody who doesn't already believe that OMM works, and in that sense, it doesn't build on the overall scientific consensus.
Mhm.
Well, it also does something that I don't agree with in general, which is it tries to spin its negative result as
Mm,
positive,
hmm.
which I think is something that as a profession we need to be more comfortable with just accepting a negative result as a negative result.
Yeah.
So, what would be your recommendations for the study if someone wanted to go back to it? Like, what would you? I know you kind of had some critiques earlier about doing multiple,
Yeah.
laps over multiple sessions, type of thing, or averaging all of
Honestly,
them, or does it just need to be, is it even worth trying to for someone else to try to come back and
it's not. It
No.
this is this I think this study should have stayed as what I'm presuming was originally a student project. And again, I think from that perspective, I commend the authors. I think they did a good job at what it is. I don't think it's appropriate for publication.
Mhm.
And I think it really muddies the waters when we're looking at OMT research in general. So I would say this is something that should stay on the student side of
Yeah.
things. And I
It would
wouldn't
make a
recommend
great
redoing this.
poster.
Absolutely. And
Not
I think as a learning exercise, this is an excellent use of your time to learn how to do research, to do experiments, to get hands-on experience. I just have a real problem with our
yeah.
society journal kind of publishing.
Mhm.
Yeah. And I'll say one of the things that could really get people started on the right foot is having more experienced people guiding the creation of research. So I
Yeah.
noticed a number of things about this project that were very easily avoidable by somebody who is trained in research methodology. And as a profession, we don't have a lot of people who are highly skilled researchers. We've got data to show that people who are more interested in research coming into and out of medical school tend to become MDs and not DOs. And even the DOs that I've met who have, say, a PhD, they don't focus on osteopathic manipulative medicine research by and large. There are a few, and hopefully they're starting to put together some really well conducted, well funded, well thought out studies. But we do ourselves a disservice by just publishing anything that tries to spin OMM as being successful. If we can trust ourselves to do the science right, then what we will find is truth. And whether that supports or refutes what we've believed all of these years, either way, that's going to put us on a more reality-based framework. And I would much rather not do the osteopathic manipulation that doesn't work so I can save my time for the osteopathic manipulation that does work.
Absolutely. Well, this is a topic that we'll have to delve into more on future episodes. We do want to thank Stephen and Al for being with us today to hash out these two articles. We do also want to remind people that if you can follow the podcast on whatever platform that you are viewing this on to be able to be notified of future episodes coming out. So do please smash that follow or subscribe to show button so you can get all that information. If you want to get more information about what's happening in DO-Touch.NET, you can go to our website, which is do-touch.net, and find out about things that are happening within the practice-based research network, or even join up to become a member of the PBRN. And you can also follow this information on the YouTube channel. And if you want to reach out to us within the information for this episode and also on YouTube, you can find our email, which is do-touch.net@atsu.edu, and you can reach out to us if you have any articles that you would like us to look at, or if you are a researcher within the OMM field and you would like to guest star on one of our future episodes. So thank you, Stephen. Thank you, Al, for being with us today. And we will speak to you all next time.
Thanks, Corey. We'll see you guys.
Great. Thank you.